everyone, and welcome to today's Public Health Ontario Rounds presentation update on invasive group-based streptococcal disease. My name is Julianne Coos. I'm a clinical microbiologist at Public Health Ontario, and I have the pleasure of moderating today's session. I would like to start by acknowledging that the land we are facilitating this virtual education session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and now is home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Now, before we begin, a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation, so please use the Q&A pod if you have any questions. There'll be a discussion and question period following the presentation, and we will make every effort to address as many questions as possible. If at any point during this session you experience any technical issues, please email capacitybuilding@ohpp.ca. And I'd like to state that as the moderator of this session, I have no conflicts of interest to declare. It is now my great pleasure to introduce the speakers for today's presentation. Dr. Leanne McDonald is a public health physician in health protection at Public Health Ontario, where she supports communicable disease work and including provincial surveillance of invasive group-based streptococcal disease and tuberculosis. She's also an assistant professor at the Della Lana School of Public Health at the University of Toronto. Dr. Alyssa Golden is a biologist in the Streptococcus and Sexually Transmitted Infections Unit at the National Microbiology Lab, Public Health Agency of Canada. She focuses on surveillance, antimicrobial resistance, and genomic analysis of invasive Streptococcus pyogenes, Strep pneumo, and Strep agalactiae. And finally, Dr. Genevieve Cadeau is the Acting Chief of Communicable Disease Control and Prevention at Montreal Public Health and a Clinical Assistant Professor in McGill University's Department of Epidemiology, Biostatistics, and Occupational Health. She has previously worked as an Associate Medical Officer of Health at Ottawa Public Health in Communicable Disease Control and Prevention. This is a sold-out session today with over 900 sites registered, so I know this is a topic of great interest. So, Dr. McDonald, let's get started.
Thank you very much, Julianne. It's a pleasure to be here today. I don't have any relationships with commercial interests to disclose. Thanks for sharing this hour with us to everyone who has registered, and we hope by the end of the hour, you're able to summarize recent epidemiological trends in iGAS activity, both in Ontario and across Canada, to understand current approaches to iGAS, including whole genome sequencing at the National Microbiology Laboratory, or NML, and then to think about iGAS outbreak management in a long-term care setting and what whole genome sequencing can bring to that. We have 3 speakers and lots to get through. We're really looking forward to the question and answer portion of today's session. I did want to note that what is out of scope for today's presentation is any in-depth discussion of clinical presentation of either invasive or non-invasive group-based streptococcal disease or clinical management. So we really encourage your questions. We encourage ideas for future sessions in your evaluation, and we look forward to getting going. So today we're talking about the invasive form of infection with a common bacteria, Streptococcus pyogenes, or group A strep, that occurs when the bacteria enter normally sterile sites in the body, such as the blood or the deeper soft tissues. We know that group A strep is a common cause of much milder infections, such as strep throat or pharyngitis, and skin infections like impetigo. And we know that transmission occurs often person to person via contact with the respiratory and nasopharyngeal secretions and lesions of an infectious person. Sharing injection drug use equipment is another way that this bacteria can spread. Unfortunately, the much more serious invasive form of the infection, while less frequently reported than the milder form of infection that's much more common, can progress very quickly to severe and life-threatening illness and even death. It presents in different ways, and that can include streptococcal toxic shock syndrome, necrotizing fasciitis, or meningitis. And fortunately, we are able to monitor trends in iGAS because it is notifiable to public health in Ontario and nationally in Canada. There are some known risk factors for invasive gas infections, and that includes being an older adult or a younger child or infant, being peripartum or post-surgical, having skin breakdown, so that portal of entry for the bacteria to enter, for example, from a burn, an injury or wound, or chickenpox lesions. Having chronic underlying medical conditions or being immunocompromised increases the risk of iGAS. And there's a role for viral infection, either recently or at the same time as a bacterial infection with gas, in increasing risk of invasive infections. So, for example, thinking about recent influenza infection or co-infection, as well as mentioned above, chickenpox is another consideration, and a reminder of taking advantage of staying up to date on vaccines for those viruses, because we do not, as of yet, have a vaccine for group A strep. Use of injection drugs, as well as experiencing homelessness, are other known risk factors for iGAS. So what has been happening globally recently in terms of iGAS activity? Interestingly, multiple jurisdictions around the world have been reporting increased iGAS activity starting in 2022, including among children. So this slide gives you an example of some of those jurisdictions, such as the UK, parts of Europe, the United States, Australia, and South America. And these increases are not yet fully understood. There's lots of interest in understanding them better and many potential factors to explore. But that brings us to Ontario. And we are, like these other jurisdictions, in a period of seeing increased iGAS activity in this province. So we're able to monitor this and compare it to what we might expect based on the past by using our provincial surveillance data that's reported in for every case that meets a case definition in Ontario. I wanted to note that while we do this on a continuous basis, we do define surveillance seasons starting in October. And this is partly because we tend to see increases in activity in the colder months, so the winter and into the early spring. All this can vary season to season. And right now we are ensuring that we can share awareness of iGAS activity through a monthly enhanced epidemiologic summary that Public Health Ontario publishes on our website. So the next report will be published in about 2 weeks' time. We encourage you to please stay tuned and share this resource with colleagues and partners as relevant. So to take a step back and look at a 10-year or a 10-season perspective on trends in iGAS activity in Ontario, we can look at 2013 to 14 through to the last complete season, so 2022 to 23 that we have data for. And we can see there is some variation season to season in counts and rates, but overall the trend seems to be an increase in iGAS counts and rates in Ontario. Some seasons had decreased activity, including the two most affected by the pandemic and the pandemic response. But from October of last year through to the end of September of 2023, we did see notably increased counts and rates of iGAS. So to look more closely at this, the figure in this slide shows the most recent data for the last 3 months of 2023 in the blue line. We've got 2022 to 23 season in the purple line, and then below that, an average of the 5 pre-pandemic seasons in the green line. And what you can see is last season, that purple line, we had an increased activity across all age groups extending into the later spring and summer months. And unfortunately, we continued to see increased activity in October through December of 2023. So we can see the highest rates remain in older adults over 65 and children in the 5 to 9 and 1 to 4 year age groups. We anticipate that the majority of cases will report hospitalization, and that continues to be the case in recent months. And of course, we have fatal outcomes reported in some of these cases. And right now, our data as of January 8th reflected approximately 8.9% of cases reporting deaths. And I just wanted to note that we do expect that additional data will continue to be reported and reflected in future updates. So there are some data lags, particularly with some of these outcomes. What about children? There's been concern in many jurisdictions about increases in iGAS in children, and it's something we're looking at very closely. We did see in the last complete season for which we have data, which is 2022 to 23, that purple line in this figure, increased activity compared to the 5 pre-pandemic seasons in those 0 to 17 years old in Ontario. So that purple line shows that we peaked in March for case counts in children last season, but that did extend into the early summer, seeing that increased level of activity. And activity has increased again in the last 3 months of October through December 2023 compared to the previous year and those pre-pandemic years for the same months. This represents about a 3-fold increase in the rate in children who are under the age of 10 per 100,000 population. And as with the overall case counts, we continue to see the majority of these cases in children reporting hospitalization. And very sadly, in the context of increased cases, we have seen fatal outcomes reported in some of these children. So as of January 8th, fatal outcomes were reported in 6 children. And when we look at updated data to January 22nd, unfortunately, we've seen some additional cases reported for this period, as well as 2 additional deaths in children. To better understand the characteristics of the pediatric iGAS cases in Ontario last season, in whom a fatal outcome was reported, we've done some additional analysis, and we found that the majority of these, so 11 of the 12 children, were under age 10. There were ranging clinical presentations and risk factors reported. And unfortunately, that rapid progression of iGAS that can occur was reflected in very short time intervals between reported symptom onset date and reported date of hospitalization and death. We're closely working with our laboratory colleagues provincially and nationally to understand any changes in the bacteria, the group A Streptococcus, causing these invasive cases, including monitoring a new hyper-virulent sub-lineage of M1, a frequent subtype of group A strep that is detected in iGAS cases. And Dr. Golden will speak to this in more detail from the national perspective, but when we look at our Ontario cases that have had the M1 subtype identified and for whom M1 UK genotype testing was done, we see that M1 isolates are now having the majority of the M1 genotype tests come back positive in Ontario. While I've spoken mostly to the provincial perspective of iGAS activity recently in Ontario, of course, there is some variation locally, and our local public health units are in our best position to understand what's happening locally. And just wanted to share that our surveillance reports do include maps, and they demonstrate some variation in the rates by public health unit. So before I hand it over to Dr. Golden, in summary, we have been seeing an increase in iGAS activity in all age groups, including children, up to the end of December 2023. It's challenging to predict what will happen going forward, but we are continuing to closely monitor it. In October to December 2023, our iGAS activity continued to be above what we would have expected compared to 2022 for those months and compared to recent pre-pandemic seasons. And we continue to see those older adults, 65 and older, having the highest rates, and are paying attention to the greater than 3-fold increase in the rate in children under 10 that we observed in the last 3 months of 2023 compared to the year previous. So thanks again for coming to learn with us today. We are closely monitoring this and really look forward to hearing from Dr. Golden and Dr. Kadia. And I wanted to say thank you to everyone who contributes to the ongoing work to be able to gather the information and share it as part of iGAS surveillance activities in Ontario.
All right, thanks so much for that presentation, Leanne. I'm going to be talking about iGAS testing at the National Microbiology Laboratory and also some iGAS trends from the national perspective. I have no conflicts to declare for this presentation. So the first part of my section is going to talk about kind of briefly the National Laboratory Surveillance of Invasive Streptococcal Disease in Canada, or the eStrep program. The eStrep program characterizes invasive Streptococcus pneumoniae, group A strep, and group B strep from neonates with the ultimate goal of monitoring trends in serotypes, EMM types, and antimicrobial resistance across Canada. We also aim to support outbreak investigations as well as inform vaccine development, vaccine guidelines, and treatment guidelines. The most important point of characterization for group A strep is the EMM or M type. And this test is performed one of two ways, either using traditional PCR and Sanger sequencing via the protocol available on the CDC's website, or via whole genome sequencing, which I will talk more about shortly. A brief overview of kind of how the program works, with the exception of one provincial laboratory that submits annual line-listed data to us. All provincial and territorial public health laboratories from across Canada, as well as all New Brunswick hospitals, collect iGAS isolates from their jurisdictions and send them on to us at NML for further testing. We perform the EMM typing as well as any other required testing and then report that data back. We generate, consolidate, and report actionable surveillance data at both provincial and territorial level and at a national level. So some examples of some of the reports that we send, we report individual results out to each provincial and territorial laboratory for further dissemination back to the regional public health unit, which the isolate originated. And then we also put together our national surveillance data for each year as an annual report that's published in Canada Communicable Disease Report. So as I mentioned, we can do EMM typing one of two ways. The first we performed for a very long time was the more traditional method using PCR and Sanger sequencing. However, beginning in fall of 2022, our laboratory transitioned to routine whole genome sequencing for all incoming Streptococcus isolates. That is quite a large number of isolates, so we batch these in groups of about 90. These get extracted using an automated robotics procedure, and then they are sequenced using Illumina technology. From that genome, we are able to extract the EMM gene and then search for the type against the CDC database. And one of the pluses to having whole genome data available is we don't just get the EMM type, we are also able to search for other pieces of crucial information, included predicted antimicrobial susceptibilities, multi-locus sequence types, and also a toxin profile. As well, we are able to use that whole genome sequence to help support outbreaks when jurisdictions request assistance in this matter, which I'll talk about again shortly. We do still perform EMM typing by PCR and Sanger sequencing. However, this is only upon specific request by a jurisdiction for urgent typing, as the Sanger sequencing has a little bit of a faster turnaround time. This slide kind of goes over our analysis pipelines for our isolates. So the fancy name we have for our program is WADE, which stands for Whole Genome Sequence Analysis and Detection of Molecular Markers. WADE was developed in-house and kind of has two different aspects to it. The WADE typing portion is our main tool, and it is publicly available on GitHub at the link available on this slide. And WADE typing contains all the different pipelines and tests for our group's 4 main pathogens, which include group A strep, group B strep, strep pneumo, as well as gonorrhea from the STI side of our lab. The iGAS specific tests in the red box I listed previously, but EMM type is our one ISO accredited test for group A strep. On the other half here, the WADE Trees is not a public-facing program, but we do use these algorithms to generate visualizations for jurisdictions when they request assistance with outbreak analysis. So if they would like to determine whether or not a number of isolates from a specific location are genetically related. And in terms of outbreak analysis, between 2019 and 2023, our unit has responded to over 60 requests for outbreak, case cluster, and special project analysis. Most provinces and territories across Canada have requested assistance at least once. And these requests are often quite variable in terms of their background. So many of them are outbreaks in long-term care facilities or hospital wards. They could be regional increases in a specific EMM type, or they could be groups of people with specific risk factors such as homelessness or substance abuse. We have looked at quite a variety of EMM types, but most recently EMM1 has been the most common. And actually, since I put this slide together last week, there have been 2 more requests. So we're up to 4 requests for outbreak analysis already in 2024. And in the last section of this session today, Geneviève will be going over an outbreak in her jurisdiction, and she's going to talk a little bit about how whole genome sequencing from our group was able to assist in that situation. The second part of my section is going to look at national iGAS trends up to 2023. It's important to note that the 2023 data that I will be presenting is still preliminary. We are still waiting for some data to come in. So just keep in mind that the 2023 numbers I'm showing you are going to change. This first slide of data is the annual counts of iGAS submitted to NML in Canada starting in 2010, which is the first year that we did this testing, up through 2023. And as you can see, from 2010 going through time, there was an increase overall in the number of iGAS isolates that were collected over time, with a dip during the COVID years. And then 2023 at just over 4,800 isolates is the highest annual count that we have seen at the lab on record. As it stands right now, the 2023 count is an over 80% increase from the number of isolates we received in 2022, and an almost 50% increase from our previous highest year, which was 2019. This next slide is the same type of figure, just for children less than 15 years of age. And as Leanne mentioned in her section, pediatric iGAS disease has been it's been increasing in jurisdictions across Canada as well as countries around the world. And obviously our data at NML kind of shows that quite clearly here. The 2023 count as it stands shows an over 200% increase in isolates from children received at the NML in comparison to 2022. Now we're just going to look at this data broken down a little bit further by month. The top panel is for all ages, iGAS in all ages, and the bottom is for iGAS in children less than 15 years of age. For 2022 and 2023, iGAS across Canada didn't necessarily follow what we would deem to be the normal seasonal trends. So in previous pre-pandemic years, generally we would see our peak counts in somewhere between December and February, and then they would slowly drop off for the summer months before picking back up again going into winter for that kind of iGAS season flow. However, beginning in late 2022, we started to see those numbers start to pick up, but they kind of didn't stop picking up. So in 2023, our peak months were actually April and May, where normally we would start seeing the numbers start to decrease by that time. In all ages, we did see a decrease going into the summer, but the trough for 2023 was actually in September, and it only lasted for 1 month before picking back up again into December. For children less than 15, we did see sustained high counts between November 2022 and June 2023, which lasted quite a bit longer than we expected. We did see decreased counts from July through to October, but it's important to note that these summer monthly counts were quite a bit higher than the normal summer counts that we would see pre-pandemic. And then as you can see in December, the count spiked back up quite significantly. If we move over now to some of the EMM typing data, this is looking at the trends in EMM types across Canada from 2019 through to 2023, with the 2023 data in the red bars for both graphs. The top graph is for children less than 15, and the bottom graph is for patients over 15 years of age or over. So as you can see from these figures, EMM1 and EMM12 were across the board the most common EMM types seen in 2023, which is consistent with reports from other countries who saw the same results. So in children, EMM1 was responsible for about 50% of isolates that we collected, and EMM12 was about 25%. So in total, 75% of the pediatric isolates that we saw were only one of two types. So for 2023, it was actually strange whenever we saw an EMM type that wasn't one of these two. For patients 15 years of age or older, it was the same thing. The two highest types were EMM1 and 12 at 20 and 16% approximately, but we did also see a high amount of EMM49 at just over 8%. EMM49 is a type that we saw increasing during the pandemic years as other types decreased over that time period. However, in 2023, EMM49 dropped back down again with the resurgence of EMM1 and EMM12. This slide looks a little bit more detail into EMM1 and EMM12, our two most common types. The top panel is counts of EMM1 by month starting in 2018. And as you can see, EMM1 was quite common prior to the COVID-19 pandemic. It was, in fact, our most common EMM type on a yearly basis until the pandemic hit. And then during that time, we collected virtually no isolates, which was just very surprising. Usually we maintain like at least some counts, but some months we received none. This all changed in late 2022 when EMM1 started to pick back up, peaking in April and May. The low point was in September, and these 2 points coincide with our overall counts that we received by month. And then after that, EMM1 counts did pick back up going into December, with December actually being our highest monthly total of EMM1 for 2023. EMM12 on the bottom panel was not nearly as common prior to the COVID pandemic, but it came kind of from obscurity into the forefront in late 2022. It increased right along with EMM1 with its peak in April of 2023. However, the difference for EMM12 is that the counts that we have seen have gradually decreased over 2023, hitting a low point in December 2023. So it'll be very interesting in the future to monitor this type to see whether or not it kind of fades back into the background or if it perhaps increases again as EMM1 has. My last slide of data here digs a little bit deeper into the EMM1 variant M1UK. As Leanne mentioned in her section, M1UK is a hyper-virulent clone of the EMM1 type that was originally identified in the United Kingdom. We differentiate the M1 UK clone from the global clone by identifying 27 key variants in the whole genome. So our traditional EMM typing system of PCR and Sanger sequencing does not allow us to perform this test. So we use the whole genome sequencing for this. In the actual figure in the bars, we have M1 UK in blue, the global EMM1 strain in purple, and then gray indicates isolates that were not tested by whole genome sequencing. We unfortunately have a bit more sparse data prior to 2018 because whole genome sequencing was not performed routinely prior to that point. But kind of the gist of this figure is that from the point in 2015 when M1 UK was first identified in Canada, there has been a sharp and significant increase in the proportion of EMM1 isolates that are this virulent clone. And in 2023, about 60% of all EMM1 isolates we received were this hypervirulent clone. So just to summarize what I have discussed in my section before I pass it off, at NML, we perform our routine typing using whole genome sequencing, and this has the great benefit of allowing us to do additional typing beyond EMM, looking for M1 UK and also assisting with outbreak analysis. However, we do continue to do Sanger sequencing for urgent requests. In 2023, we saw the highest annual count of isolates submitted to the NML, and this increase was particularly noticeable in children less than 15 years. The increases that we saw were primarily associated with EMM1 and EMM12, and about 60% of the EMM1 isolates we saw were the M1 UK clone. And we have been getting quite a few questions over the course of this terrible iGAS season about severity and association of severity with EMM types. And unfortunately, because we're currently laboratory based, we don't have any of that information. So in the future, establishment of a national enhanced surveillance system for iGAS will help us kind of put that data together and hopefully assist more with answering those types of questions. And then lastly, I would just like to acknowledge all of the public health laboratories that help make our iGAS surveillance possible, as well as all of my coworkers and colleagues at the Streptococcus and STI unit at the NML. Thanks for having me.
All right, thanks very much, Alyssa. So I don't know about you, but I found that really interesting to find out how the testing is done at the NML, really useful for local public health units. So I'll be speaking to a recurrent EMM89 invasive group A strep outbreak that we had in a multi-level elder care facility in Montreal. So I have no conflict of interest to declare, but I would like to acknowledge many different people who helped manage these two outbreaks. So the outline for my talk, so I'll begin by describing our two outbreaks, so the initial outbreak and the recurrence. Then I'll go on to describe some of the contributions of laboratory analyses to outbreak management, and I'll finish off with some key barriers and facilitators to outbreak detection and management. But before I get started, let's quickly review the guidelines we have available for managing iGAS outbreaks in long-term care facilities. So what I'm citing here are the correct guidelines, but they're very similar to the federal guidelines. They're both a bit dated, so they date back to 2006 and 2007. Nevertheless, let's quickly review. So there are guidelines for declaring an outbreak or confirming the existence of an outbreak. That guidance at the moment doesn't take into account M-typing or whole genome sequencing. And there are also guidelines around what interventions are recommended to control the outbreak. And those focus around enhancement of IPAC measures, mass screening of residents and staff, and targeted prophylaxis of those who test positive. So let's begin with describing our two outbreaks. So the setting for the outbreak was a building that had two different towers that were joined on the ground level by a shared lobby. So on the bottom level of the two towers, you had the long-term care areas, then you had intermediate care, and then you had a retirement home in the top levels. The rooms were mostly single rooms, and there were no baths or showers in the rooms. So those were located in common areas on each of the floors. In terms of the people in the setting, their level of autonomy was limited. So 20% had severe neurocognitive disorders, including a locked unit for people with wandering. 70% were semi-autonomous, and only 10% were considered autonomous. In terms of the employees or the staff in the building, so the non-healthcare staff was provided by the private management company that ran the building, the facility. The healthcare staff for the long-term care and intermediate care was provided by the public sector sub-regional health authority. And so in Montreal, there are 5 sub-regional health authorities, and so it's based on territory. So the sub-regional health authority for that territory provided the staffing. And as well, there were 4 other sub-regional health authorities that rented beds in that facility, and they provided some specialized clinical staff for some of those patients. And all of those entities also relied on some temporary agency staff to fill some gaps in staffing. So here's a quick summary of the outbreak in terms of numbers of cases. So you can see here that in the initial outbreak in 2018-2019, we had 8 iGAS cases, all among residents. And in the recurrence, we had 6. In both outbreaks, all but one of the iGAS cases were considered clinically severe. And in both outbreaks, all but one of the clinically severe cases were fatal. You can see that the number of non-invasive gas cases and carriers was much higher in the initial outbreak than in the recurrence. And it's shown here by the ratio of iGAS to gas cases, so 1:5 versus 1:3. And we think the reason that is that the initial outbreak was essentially simmering for several weeks before being detected. And you'll see this when I show you the epi curve. So this is the epi curve for both outbreaks. So for the initial outbreak, you can see that there was a big gap of time, more than 30 days. So it didn't meet the outbreak definition as per the guidelines. So more than 30 days between the first and the second case. And again, more than 30 days between the second case and the third case. So the outbreak didn't get detected until the 4th case. And so during all this time, there was probably transmission happening. And this is probably what led to such a high number of carriers being detected. In contrast, in the 2022 outbreak, we had 3 iGAS cases in close succession, and so that led to a rapid detection of the outbreak. So where are the cases located in the facility? So in both outbreaks, there were 0 cases in the long-term care area of the facility. So all the cases were limited to the intermediate care and the retirement home floors. In both outbreaks, the outbreak was mainly concentrated, or the cases, I should say, were mainly concentrated in Tower A. But in the initial outbreak, the outbreak went on for a longer time, and towards the end, there was spread with 1 case in Tower B. The key risk factor that we found most frequently among iGAS cases in both outbreaks was wounds. So very frequently found in those cases. In terms of the site of the iGAS infection or the clinical presentation of those iGAS cases, in the initial outbreak in 2018-2019, it was predominantly pneumonia, whereas in the subsequent or the recurrence, it was predominantly cellulitis. So now looking at the contribution of laboratory analyses to outbreak management. So these laboratory analyses contributed to confirming the outbreak recurrence, and as well, they helped us define the scope of each outbreak. So we use the analyses to help determine which cases and carriers were related to the outbreak. And we also used it in 2022 to see if the outbreak had spread to another facility. So in August 2022, about 3 months into the outbreak, there was a second outbreak detected at facility, we'll call it facility B. This is a facility that was owned and operated by the same private company as facility A. It was located less than 10 kilometers away, and there was some shared staff, not a lot, but some shared staff, including some clinical staff. And it was the only other facility with an iGAS outbreak in Montreal at the time. So we had a pretty strong suspicion that, oh, this might be the same outbreak that is now spreading to another facility. So looking at M typing specifically, it was very useful in this outbreak. It provided rapid preliminary detection of a possible recurrence of an outbreak. And so that really helped raise the alert level internally and with external partners. People remembered what the initial outbreak had been like in 2018, 2019, and obviously they didn't want a repeat of that situation. M-typing was also used to exclude a few non-invasive gas cases and carriers from the outbreak because they had different M-types. And however, it was misleading and initially led to a more aggressive response when we detected that outbreak at facility B. So because M-typing is available quicker, so we get the results within 2-3 days usually when we ask the NML, because it's available quicker, when we detected that potential spread to facility B, we told ourselves, okay, let's wait and see what the M-typing is like. And if it's the same, then it's probably, given all the epi links, it's probably the same outbreak that's spreading. And so the M-type turned out to be the same. They were both EMM89. So we concluded, oh, this must be the same outbreak. And so we were very aggressive in how we approached it at facility B. However, had we waited for the whole genome sequencing, which took another week or so, we would have seen that they were in fact 2 different outbreaks. And so that brings us to the whole genome sequencing. So very, very useful in these outbreaks. So it allowed us to confirm the recurrence at facility A. So there was only a 5 to 6 SNV difference between the initial and the recurrent outbreak isolates. And given that the presumed rate of genetic drift is small, it suggests that it was, in fact, a clone of the initial outbreak that caused the recurrence. Similarly, whole genome sequencing allowed us to rule out spread from facility A to facility B in 2022 because the SNV difference was much higher. We're talking about 39 or so SNVs. And so this slide, thank you, Alyssa, who provided the slide. This slide shows you exactly what I just said, but with a picture. So you see all the isolates, all the EMM89 isolates for Quebec are represented here. The outbreak at facility A from 2018-2019 is in pink, and the recurrence is in blue. So you can see they all cluster together. And then the outbreak at facility B in 2022 is the one in yellow and orange, and you can see that they're further away from the other outbreaks. So now moving on to some key barriers and facilitators to outbreak detection and management. So starting off with barriers to outbreak detection. So we noted 3 key barriers to detecting these outbreaks. The first one was that treating physicians and hospital laboratories failed to report 3 of the 6 iGAS cases involved in the 2022 outbreak. A second barrier was the failure to recognize the prior occurrence of other iGAS cases in the same setting. That's for the initial outbreak in 2018-2019. You'll recall that provincial guidelines and federal guidelines tell us to consider a 30-day period when defining an outbreak. In this case, had we extended that period further and taken into account M-typing and whole genome sequencing, we would have known that the outbreak was already smoldering before we actually were able to confirm the existence of the outbreak with the guideline. And finally, there was a failure to reassess the possibility of a link between cases when M-typing became available. So that wasn't integrated in our processes. So essentially in 2022, when we first detected the outbreak, the first case was on the 2nd floor in the intermediate care setting, and the second case was on the 3rd floor in the retirement home setting. And we were told that it's different staff, one's provided by the public sector, the others were provided by the private sector. There's no way that these cases could be related. There is absolutely no, staff mobility and no equipment mobility and so on. And so we accepted that conclusion, and we didn't revisit it when we received the M-typing results as we should have. And we've definitely changed how we do things so that this doesn't happen again. Some key barriers to outbreak management. One of the key ones was unclear governance. So the governance was unclear both between us at Montreal Public Health and the sub-regional health authority whose territory the facility was in and who was staffing the long-term care and intermediate care sections of the facility. And also it was unclear between that sub-regional health authority and the 4 who rented beds in the facility. Another key barrier was deficient management of the private care facility. So there were important leadership issues, both in administrative and clinical leadership. There were staffing issues, there were important quality of care issues, and all of these issues put together meant that there was essentially a failure to effectively implement outbreak control measures. So what do I mean by that? So we tried to do mass screening of residents and staff, and it took months to get a reliable list of staff working in the facility. There was low uptake of screening among staff, especially in 2022, and we think that was related to pandemic fatigue, and unscreened staff continued to work in the facility, at least initially. When we tried to implement mass prophylaxis of residents, we realized that several residents who had been prescribed prophylaxis were not provided it. And so we only realized this because we kept getting cases, iGAS cases among residents. And when we would go back and we would see that, oh, well, they hadn't been prophylaxed and they weren't the only ones. And there were several issues with IPAC practices. So when we first detected the outbreak, the hand hygiene compliance rate was below 20%. There was inadequate environmental cleaning and disinfection. There was no wound care registry. There was no wound registry, and there were deficiencies with wound care. So what were the key facilitators for controlling the 2022 outbreak? So sad to say, but a key facilitator was the fact that a family member made a complaint about resident mistreatment, and the Ministry of Health launched an independent inquiry into the quality of care and resident mistreatment. That quickly led to the takeover of management of that private facility by the public sector. And so some key staff were transferred over to the private facility to help manage it. And as well, several of the residents that were in the facility were transferred to other facilities that weren't facing the same kinds of issues. So it helped bring the headcount down. Human resources management improved gradually. So eventually we got staff lists and were able to implement effectively staff screening, and unscreened staff were also eventually prevented from working at the facility. And finally, there was an IPAC action plan that was developed and implemented. And among the various actions that were taken, one of the key ones that really was a turning point was when the public sector that was now running the facility decided to make it mandatory for all healthcare staff to undergo IPAC training and to take a test. And if you failed the test, you couldn't work there anymore. And there were many staff who failed the test and couldn't work there for a number of weeks. But they asked their managers if they could receive more training and retake the test. And the majority of them did. So they retook the test, they passed the test, and they ended up working at the facility again after that. But it really helped change the culture in that environment and take IPAC seriously. So in summary, collaboration between regional public health and sub-regional health authorities was necessary to control these outbreaks, but was impeded, unfortunately, by unclear governance. There were several factors at Facility A that impeded outbreak control and likely contributed to its recurrence. Timely access to whole genome sequencing was instrumental in understanding both the recurrence of the outbreak from 2018 to 2022, as well as the scope of the 2022 outbreak. And finally, of course, iGAS outbreak management guidelines really need to be updated to take into account some of the new laboratory techniques that are now available to us. So thanks very much. And I believe we'll be moving on to the question and answer portion of the session now.
Thank you, Dr. McDonald, Dr. Golden, and Dr. Cadieux. We'll now move on to the Q&A segment of this event to address some of your questions. I know there's a lot of interest, and this is a really large topic. We're going to focus our questions that are pertaining to the presentation today, and will not be able to address comments or questions related to clinical management. So please continue to enter your questions into the Q&A pod if you've not already had the opportunity, and we will begin going through some of these questions. There are a lot already. So I don't know if I should start off with this big one. I think this is the elephant in the room. A lot of people are interested to know, why are we seeing this huge number of increased cases? And is this perhaps an unintentional consequence of the pandemic that included distancing, masking? Do we have any hypotheses as to whether or not this has impacted the number of cases that we're seeing, or other hypotheses? So I'll open that one up. Dr. McDonald, do you want to take a stab at that first?
Thank you, Julianne. So the short answer is that the increase is not yet fully understood. And the longer answer is that there are a number of factors that are likely contributing. And I think it's helpful to take an even longer time perspective, because if you look back over 10 years and more, iGAS activity in Canada, but also in other jurisdictions, was already starting to increase. So certainly we did see a decrease in iGAS reported in Ontario and many parts of the world during the pandemic in the context of public health measures designed to limit spread of many different infections. And we saw a decrease in not only iGAS being reported here and in other places, but decreased circulation of other bacterial and viral infections. So that is, part of the context temporally of seeing that decrease and then the subsequent increase. But I think really understanding how multiple different factors are potentially contributing to this increase is something that continues to be examined. It's part of why we are trying to look more closely at some of the additional surveillance data we are collecting in Ontario, for example, about risk factors, to try to understand, are there characteristics of the people who are developing iGAS that are more commonly being reported. It's part of why this partnership with our laboratories and really trying to understand, is it something about the bacteria that's more likely to cause invasive disease that's changing these emerging sub-lineages? How do they map to clinical and other epidemiological characteristics of the cases that we're seeing? So these are really important questions. Of course, there's interest in patterns of respiratory virus activity in the context of increases, particularly at times of year, in the late fall and winter, when we have been, we expect and we do see increased viral illness circulating. We know that a preceding viral infection, for example, with influenza, or a co-infection, can increase the risk of iGAS. And so we're interested in ways to continue better understanding that relationship. But I think one piece of the picture that we don't have in public health is the level of circulating non-invasive group A streptococcal illness, just to understand the relationship of those invasive cases to what is circulating in the community. But again, this is something that many colleagues in public health are interested in continuing to work on, and also in the research world. So I'll welcome others to comment.
I don't have anything else to add to that. That was a very good answer.
That was a great answer, and you hit on actually a lot of topics that are coming in through the chat. One other question is related to the pediatric cases and poor outcomes. You kind of alluded to, trying to investigate whether or not there's differences between or similarities between the bacteria versus the patients. Do we have any specific, can you speak to the specific M types that at least we've been seeing in Ontario or maybe nationally that have been associated with the poor outcomes in pediatric patients? Are there a wide distribution of M types, or are they mostly M1 at this time?
I can start, and then maybe Alyssa, you might want to add from that national perspective, and Geneviève maybe from the Montreal perspective as well, from what you've seen. So I think the big picture here is that we have continued to see multiple different M types being reported in the context of this increase. Dr. Golden spoke to some of the most frequently observed in the past year, and for us in the past season. So that would include M1 and M12. However, we've seen many different M types reported, and Public Health Ontario has published an initial report on the 2022-23 season, so 12 months of data, where we described the variety of M types that were observed. We're interested in trying to understand that data a little bit better by looking at, among the most frequently reported M types, what is the clinical severity profile? Are there risk factors that are different for certain M types, or populations that are different by age, for example, or by setting, being impacted differentially by different M types? So there certainly is more work underway to try to understand that better. But in our very small analysis of the pediatric cases in whom fatal outcomes were reported between October of last year and September 2023, we, at the time of the analysis, didn't have M-type data available for all the cases, but among those that we did have cases, we saw the two M types that were most frequently reported overall in our cases. So again, we need to continue to try to build our understanding around this more.
From a national perspective, unfortunately, I can't speak to what EMM types were associated with increased disease severity or fatalities, just because we don't receive that data at the National Microbiology Lab. So as I had mentioned, the development of that enhanced iGAS surveillance program would really go a long way in helping us understand more about that from a national perspective.
Okay, we'll move on to an easy one. And so the question is, which iGAS are sent to the NML, or which gas are sent to the NML? Are they just iGAS or all gas? So I can answer that because we facilitate sending those on to Alyssa from PHO. So at this time, it's all iGAS. We encourage the sending to the NML. It's not mandatory, but it is highly encouraged for these national surveillance initiatives and provincial surveillance initiatives. In the case of an outbreak investigation, if we have non-invasive isolates that are detected through screening programs, we can send those non-invasive isolates onto the NML, as was done in the Quebec outbreak, and I think was extremely helpful in understanding. So if that's the case, just contact if you're in Ontario, contact Public Health Ontario Laboratory, and we will help assign an outbreak number or an investigation number and facilitate getting those analyzed by our partners at the NML. So Alyssa, a question about whole genome sequencing. I know there's a lot of, it's very exciting. It's moved into, routine use more and more, but, it's still a new technology and there's a lot of questions about it. And there's a lot of learning to be done on how to use it in outbreak management. And that differs from organism to organism, I would argue. So you produce a lot of data when you sequence the entire genome. You talked about some of the things that you pull out of there in understanding the organism. Is there anything else that you think you could be using this additional data for? Like, can you extract anything additionally from that for understanding what's going on here? And then if you want to just maybe remark on whether or not there are, what the pros and cons of this approach might be.
Sure. So I can start with pros and cons. Like, whole genome sequencing is fantastic because you do one sequencing reaction and you get the entire genome. You don't have to run a separate test for EMM type and then a separate test for susceptibility testing and then another set of PCRs to get all the toxins. So you get all that information rolled into one with one test. And that is truly the best part of it. Some of the drawbacks include the fact that, it does take a little bit longer to turn around a whole genome sequence than it does to just do one Sanger sequence for an EMM type. And there is a bit of kind of a technological barrier to doing whole genome sequencing because you do need to have the technical capacity and staff to, do additional things such as full extraction procedures, library prep, and then the physical sequencing itself, not to mention the analysis. So that is a big barrier to overcome. In terms of, the things that you can get from the whole genome sequencing data, as I mentioned, right now, we mostly look at EMM type, susceptibility, toxins, and MLST. However, there definitely are more things that we could dive into. Virulence genes are always of particular interest. And, sometimes there's specific requests that come in for in an outbreak situation, like, oh, we're wondering if these isolates are associated with this virulence factor or this toxin, things like that. So generally right now we kind of just focus on those main things, but then we can look for other things upon request. And I guess, yeah, from an outbreak analysis perspective, group A strep doesn't have a particularly fast mutation rate. So it works well for whole genome sequencing analysis because we know the expected genetic drift. We know that for isolates to be considered related, they usually fall within 7 to 10 single nucleotide variants in the genome. So it makes for a very helpful tool in analyzing outbreaks to determine what isolates are related and which ones aren't.
Okay, Dr. Cadeau, your turn. Lots and lots of interest online about your outbreak investigation. I don't even know where to start, but maybe we can start big picture. So what do you think the key updates for the outbreak management guidelines would be, or would you like to see that may help you in future situations?
Yes, so several updates. I think, first of all, including the role of all the new laboratory techniques and how do we use them to detect the outbreak and to monitor the outbreak as well. So including that, I think certainly the role of mass prophylaxis needs to be at least discussed in the new guidelines. When do we use it? Is it effective? Under what circumstances might it be considered? And I have to say, in our outbreak, it was our colleagues from the Sub-Regional Health Authority, our med micro and infectious disease colleagues who suggested it. And it was really a risk mitigation measure because we were so unconvinced that screening was going to be implemented effectively that it was decided to prophylax just the residents because they're obviously at higher risk of developing iGAS and dying than the staff are. So it was really a risk mitigation strategy in that case. But yes, so speaking to the potential uses for mass prophylaxis would be one. And also, I think there needs to be escalation that needs to be discussed in these guidelines because you can do multiple rounds of screening and not get control of the outbreak. So what do you do when you've tried the initial steps that are recommended and it's not working? So I think that would be another key aspect that should be discussed in the guidelines.
I feel like I have maybe one quick question, time for one more. What do you mean by a wound registry? This is very practical.
So very practical indeed. So from what I understand from our clinical colleagues who are directly involved on the ground in managing this outbreak, it's a common practice. It's perhaps standard of care to have a registry of everyone in your facility that has wounds, and so that you can follow them regularly and ensure that there is adequate management of those wounds. And that wasn't present in the facility initially, and I would say that our colleagues from the public sector were very surprised that it wasn't present. And so that's what they put in place. So it's not a provincial registry by all means, it's a local facility level registry.
So I think we are out of time. I just want to, thank all of the presenters today, Dr. McDonald, Dr. Golden, Dr. Gaddu. I think it was extremely valuable, and we were not even able to touch half of the questions. There's a lot of interest in this. So, I think that we'll have more to come. So I would encourage that you'll be expecting a brief anonymous PHO round survey for today. Please try to complete this to help improve our programming. As a reminder to everyone, the Ontario Public Health Convention will be held March 26th and April 3rd in 2024. So check the website for details. And lastly, to access past presentations and view confirmed and upcoming sessions, please visit the PHO website, head to education and events, and click on presentations. Just want to thank everybody for attending and to our presenters again, and have a great day.